Hello everyone. In today's session, we are going to discuss about measles. Measles, also known as rubeola. It is a continuation to our chapter Epidemiology of Communicable Diseases in our community medicine. In this session, we will discover about the definition, the problem statement, etiopathogenesis, the clinical features, which is nothing but the signs and symptoms of measles. We will also discuss about the complications of measles. Measles in relation with epidemiology, that is nothing but the epidemiological determinants, which is the agent, host, and environment. Levels of prevention of measles, the differential diagnosis to measles, the diagnosis, and a little about a discussion on the treatment of measles. Begin with the definition. Measles or rubeola, it is an acute, highly infectious disease. So we see it is a highly infectious or highly contagious disease, and it is an acute disease. Contagious, it means it is infectious. It spreads rapidly from one person to the other person. And it is an acute disease, a respiratory viral disease. There is a characteristic clinical picture of measles, a rash, and a pathognomic ananthem Koplik spot. Here they are talking about ananthem. So what is the difference between exanthem and ananthem? Exanthem is a medical term which is used for the widespread skin rash. If the skin rash is widespread, then we tell it as an exanthem. Here they are saying the Koplik spot is ananthem. So, what is an ananthem? Ananthem, also known as ananthema, it is a rash. They are the rashes which are found in the mucous membrane. When the rashes are found inside the body, so it is found inside the mucous membrane, the mouth, okay? The mucous membrane of the mouth, the Koplik spot is found. So, it is ananthem. Problem statement of measles. Measles is endemic in most parts of the globe. We see it is an endemic disease, which means the normal frequency. Each year, a certain people will be suffering with measles. So, every year the same frequency is observed, then it is known as an endemic disease. It is always persisting, but in the usual frequency, just like the common cold and cough. Every year in spring or in winter, people suffer with cold and cough and those common viral diseases. So we see it is an endemic disease. Similarly, measles is an endemic disease in most parts of the globe. It is an endemic disease. Epidemics occur when 40% children become susceptible. So when is the measles considered to be an epidemic? So we need to know the definition of epidemic. What is an epidemic? When the normal frequency exceeds the limit, okay, when it is occurring in excess frequency than what was expected. For example, every year 50 cases of measles were expected, but now it is affecting 1000 children, 10,000 children. So now it has turned into an epidemic. It is an excess frequency than the normal. 40%. When do we consider it to be an epidemic? We consider it to be an epidemic when it is affecting 40% of the children. 90% infection when it is introduced into a virgin community. So if the measles is affecting a community which was previously unaffected, 90% are infected, then it is considered, and then 100 to 400 times more deadly in developing countries. So we see that when we look into the problem statement of the measles, it is an epidemic when the proportion of susceptible children are reaching to 40%, and when the disease is introduced into a virgin community, 90% of the community gets affected. Then next we see the other problem statement is, while measles is now rare in the industrialized countries, it is still a common illness in the developing countries. Okay, and the CFR, the case fatality rate is 2 to 15% compared to 2 per 1 lakh in developed countries. So what did I tell you now? I told you that the measles, even though in the industrialized countries it is very rarely found in the developed countries, whereas it is a very common illness. It is a very common illness in the developing countries. So, in the developing countries, it is still a common illness. It is 2 per 1 lakh individuals in the developed countries. 7 to 8 million deaths are recorded before the vaccination was started for measles. So we see about 7 to 8 million cases were recorded when the vaccine was still not introduced into the community. Okay, so this is just about the problem statement, because we don't actually ask these problem statement in your university exam. So just for your information, it's good to know that the measles is endemic. It is epidemic when 40% children are affected, 90% infection when it is introduced into a virgin community, and 100 to 400 times it is deadly in developing countries, whereas in the developed it is just affecting 2 out of 1 lakh individuals, and the case fatality rate is 2 to 15%. 7 to 8 million deaths were recorded before the vaccination was started. Moving further to the incidence of measles, 2,42,000 measles deaths are recorded globally. 1,200 deaths are occurring every day, or 50 deaths per hour are occurring because of measles. So 50 individuals are suffering and dying out of measles per hour. 95% of deaths are mostly observed in the poor countries. Most common reason for the death is the failure to vaccine all the infants. India in 2005 showed 52,454 cases with 55 deaths. Underreporting, it was very common in India. Measles was very common in India. So we see India, though it is a developing country, still a developing country. So measles is very commonly found in India. Let's move further to the etiopathogenesis. Measles virus is a RNA virus which belongs to the genus Morbillivirus virus of the Paramyxoviridae family. So let us begin with the etiopathogenesis. Etiology, that is the cause, and we are going to discuss about the pathogenesis. Okay, what is happening inside the body? Once the individual gets affected with measles, what are the things which are happening inside his body, the pathogenesis, and the etiology. So we know the etiology. What is the causative factor of measles? The cause is the measles virus. It is a viral disease, acute, highly contagious viral disease. So measles virus, it is an RNA virus. The measles virus belongs to the genus Morbillivirus of the Paramyxoviridae family. It is transmitted by direct contact with the respiratory secretions. It is mainly through the exposure to aerosols and infectious droplets. So how does the measles get transmitted from one person to other? Okay, from the respiratory secretions. So from the respiratory secretions or the aerosol, the droplets into the air, the other person inhales them and gets infected. Okay, they enter the nose and via the respiratory tract, the other person gets infected with measles. Patients are contagious from 1 to 2 days before the onset of symptoms, up to 4 days after the rash appears. So we need to remember this thing here. When is the person infective? He is infective 1 to 2 days before the onset of symptoms, generally 3 to 5 days before the onset of rash. Okay, let us consider the appearance of rash. When is the person infected? Before the appearance of rashes on his body, 1 to 2 days before the onset of symptoms, 3 to 5 days before the onset of rash, and 4 days after the appearance of rash. Okay, 3, 4, 5. Rash, 3 to 4 days before the appearance of rash, and 3 to 5 days before the appearance of rash, and 4 days after the appearance of rash. Measles virus invades the respiratory epithelium and spreads via the bloodstream. That is nothing but viremia. When the virus enters into the blood, then it is known as viremia. Then it leads its pathway into the reticuloendothelial system. So we know the reticuloendothelial system is made up by the organs such as spleen, lymph nodes, and bone marrow. Then it also infects the white blood cells, especially the monocytes. So the virus first enters into the bloodstream via the bloodstream, that is viremia. It enters into the reticuloendothelial system, the spleen, lymph nodes, bone marrow, and then it also enters into the white blood cells come into play, and especially the monocytes are involved. The respiratory and lymphoid tissues have pathognomic multinucleated giant cells. So, guys, we know in measles we have this pathognomic cells known as Warthin-Finkeldy cells. So, we need to know two things here. Pathognomic. What is pathognomic? Pathognomic means a symptom or a sign which is characteristic to that specific disease. So we see we have examples like in measles, the pathognomic is Warthin-Finkeldy, and we have the scoplic spot, which is a pathognomic sign of measles. And on the histopathological view, we see in the microscope we can observe this Warthin-Finkeldy cells. These cells, they are characterized by grape like cluster of round nuclei. They will overlap each other and they are uniform in size. Okay, you can see here, this is the microscopic view. They have a grape like cluster of round nuclei and they are uniform in size. Infection of the entire respiratory tract will produce generalized damage with the loss of cilia. So we were discussing about the histological view. What did we see? The respiratory and lymphoid tissues have pathognomic multinucleated giant cells with inclusion bodies in the nucleus. So we saw here the multinucleated giant cells, and in the nucleus there is the inclusion bodies and the cytoplasm. Okay, and with the inclusion bodies which are found in the nucleus and in the cytoplasm, and this multinucleate giant cells with inclusion bodies found in the nucleus and cytoplasm are nothing but the Warthin-Finkeldy cells. Infection of the entire respiratory tract will produce the generalized damage. So I told you here the respiratory tract comes into the play, is affected. So we see there is loss of cilia. So the cilia is completely lost. The cilia are lost in the respiratory epithelium. There is a damage and there is a predisposition to secondary bacterial infection. Initially, we know it is a viral infection. The virus, the measles virus, is causing the measles. Later on, once the virus plays its role, later, secondarily, the bacterial infection occurs. There is characteristic cough, coryza, bronchitis, and pneumonia. So once the measles are playing their role, the measles virus are playing their role, secondary bacterial infection occurs, and there is cough, coryza, bronchitis, the bronchus. There is inflammation of the bronchus, and there is also pneumonia. The immune reaction of measles virus in the endothelial cells of the cutaneous capillaries. So we see there is some immune reaction of the measles virus. Once they enter into the endothelial cells of the cutaneous capillaries, they are accounting for the pathognomic Koplik spot and the cutaneous rashes. The immune reaction of the measles virus is leading to this pathognomic Koplik spot and the cutaneous rashes, the rashes which you can see on the skin. The pathological changes in measles encephalitis. So we know secondary bacterial infection. So what you have to keep in your mind is primarily the virus comes into role, and then the virus will enter into the bloodstream. It causes viremia, and then it enters into the reticuloendothelial system, lymph nodes, bone marrow, liver, and then later what happens, the immune reaction occurs, and this immune reaction is leading to the pathognomic Koplik spot, and then we have the pathological changes in the once it enters via the bloodstream. If it affect the brain, once the brain gets affected, we see that it is leading to encephalitis. So what is encephalitis? The inflammation of the brain because of any virus, a viral infection, is known as encephalitis. So we move further that what are the changes we observe in cases of encephalitis is the focal hemorrhage, congestion, and perivascular demyelination. Okay, we observe the congestion, hemorrhage, congestion, and perivascular demyelination. We know the demyelination is nothing but the covering of the brain tissues is lost. The myelin sheath will be lost. There is demyelination. Moving further to the pathogenesis of measles, you can see it is transmitted. It's just what we discussed now. You can quickly go through how is it transmitted. You can answer this very well. How is measles transmitted? Measles is transmitted by the droplets of measles, the virus, that is paramyxovirus. It will infect what? Which system does it affect? It will obviously affect the respiratory system. It will enter through the nose. So it infects the epithelial cells. There is a loss of cilia, right? There is a epithelial cells will get affected of the nose, and also affects the conjunctiva. There is also inflammation of the conjunctiva. Moving further, the virus will multiply in the epithelial cells, then it will extend to the regional lymph nodes by the way of lymphatic system. So once it gets multiplied and later it enters to the lymph nodes via the lymphatic system, it gets captured or it gets extended to the lymph nodes. And primary viremia occurs. So it enters into the bloodstream. So primary viremia will occur. The virus further continues to replicate in the epithelial cells and also the reticuloendothelial system. The secondary viremia occurs. Secondary viremia is when the virus from one organ will start spreading to the other organ. So I said you primary viremia occurs when there is a spread of the virus to the bloodstream from the original site of infection. What was the original site of infection here? The original site of infection was the epithelial cells of the nose. The respiratory tract was first initially affected, but now from the respiratory system, it is now further extending into the other organs via the reticuloendothelial system. It is affecting the spleen, the bone marrow, the lymph nodes are getting affected. So it is this secondary viremia occurs, and then there is infection is starting. There is fever, malaise, coryza, conjunctival infection, cough. So this is the prodromal period. Before the appearance of rash, the prodromal period, 8th to 12th day, there is fever, malaise, coryza, cough, conjunctival infection, and then on the 13th to 14th day the Koplik spots appears. A very important thing, when does the Koplik spot appear in measles? On the 13th to 14th day the Koplik spots is seen. Okay, we'll discuss in detail about the Koplik spot in the further slides. The rashes will erupt, that is the maculopapular rashes, and mainly the centrifugal rashes are seen. The rashes later advancing to the trunks, and the rashes seen, the centrifugal rashes are seen on 14th to 15th day. I hope the pathogenesis is clear. What is the pathogenesis? Can you give me a gist? So we see it is transmitted to the respiratory epithelium, and from the respiratory epithelium it will get multiplied. After multiplying, it will enter into the bloodstream. From the lymph nodes, it will enter into the via the lymphatic system. It will go to the lymph nodes, the regional lymph nodes. Then it enters into the bloodstream. The viremia occurs. Then it enters into the reticuloendothelial system. Then the secondary viremia occurs. Once the secondary viremia occurs, the patient starts with primary symptoms, that is the prodromal symptoms. The prodromal symptoms are those symptoms which occur before the appearance of rashes. They are fever, cough, coryza, conjunctivitis, etc. And then comes the Koplik spot on the 13th to 14th day, followed by the rashes, and the rashes are advancing to the trunk. So, this is all about the pathogenesis of measles. I hope it is very clear to you guys. Let's move further. The period of communicability is during the period of coryza. We have already discussed this. What did we discuss? Let us consider a rash, appearance of rash, 3 to 5 days before the appearance of rash, and 4 days after the appearance of rash. Okay, you can remember this very well. 3, 5, and 4. Okay, 3, 4, and 5. Clear. Let's move further. The Koplik spot. What is this Koplik spot? Koplik spot is described as a red patch with a central white specks in the buccal mucosa, especially it is located in the second molar. A very important thing, they will look like sand, okay? You can see here, I guess there's a picture in the next upcoming slides about the Koplik spots. We will see that there is appearance of a Koplik spot, especially in the second molar. The measles virus is a single-stranded RNA virus. It is unsegmented. There is an envelope which is lipid-containing. It is helical symmetry and it is replicating in the cytoplasm. The measles vaccine, about the treatment part. Okay, I'll tell you about the treatment later, but for now, just because we're taking a gist of measles, the measles vaccine, MMR vaccine, measles mumps rubella vaccine, live attenuated 12 to 15 months of age, it is given. In biopsy of the lymph node, there is a presence of Warthin-Finkeldy or the multinucleated giant cells. We discussed about this earlier, about the multinucleated giant cells on the biopsy. When we look into the lymph nodes, we get we can see the presence of Warthin-Finkeldy or multinucleated giant cells. There is presence of HA or heme agglutinating activity and F protein. There is also presence of heme agglutinin activity and also F protein are found. Moving further to the clinical features of measles. So the clinical spectrum of measles is first discussed about the prodromal phase. So now let us discuss first about the prodromal phase. The prodromal phase is 2 to 4 days. It is the most infectious phase. The prodromal phase is the most infectious phase, and the catarrhal stage with the upper respiratory symptoms like cough, coryza. We've already discussed this, right? The prodromal stage, it begins like around 10 to 14 days after the infection. You can see 2 to 4 days it is most infectious in 2 to 4 days, but the prodromal stage will begin 10 days after the infection. It is characterized by what? The fever, cough, coryza, sneezing, nasal discharges, and we have conjunctivitis, lacrimation, redness of eyes. There is high grade fever, and also there is a presence of appearance of rashes, and there is presence of photophobia. There may be vomiting or diarrhea as well. A day or two before the appearance of rash, the Koplik spot. So we are discussing about the pathognomic enanthem. It is an enanthem. It is found inside the body. It is found on the mucous membrane. So it is an enanthem. It is a Koplik spot. It is appearing as 1 to 2 mm blue-white spots on the buccal mucosa. We see that the Koplik spot, it will look like a table salt crystals. They'll appear like a table salt crystals. They are found on the buccal mucosa opposite to the first and second lower molars, especially alongside the first and the second lower molars. You can observe them. And Koplik spots may spread to involve the lips, the hard palate, the gingiva, etc. They may also occur in the conjunctival folds and also in the vaginal mucosa. The spots usually will disappear once there is appearance of rash. Okay, they're small, they're bluish white spots, they have a red base, they are smaller than the head of a pin. You can see those spots, they will appear like a salts of grain and grain of salts, and these rashes like the table salts, you can find them, and they are smaller than the head of the pin. Their presence is a pathognomic of measles. The characteristic maculopapular rash. Now we are going to discuss about the eruptive stage. In the eruptive phase, what happens? There is a characteristic typical dusky red maculopapular rash. The maculopapular erythematous, reddish, okay, dusky red rash. It begins at the hairline on the forehead and behind the ears. So we see the rash is beginning in the hairline of the forehead. It is beginning on the hairline of the forehead and also behind the ear. It is found on the hairline, beginning of the hairline, and behind the ears. It is spreading down to the trunk and limbs, including the soles and the palms. So you can see here it is beginning on the forehead, behind the ears, and then spreading to the trunks, arms, and legs. By the fourth day, the fever and rash will begin to fade. Just by the fourth day onwards, the rashes will begin to fade. There is desquamation, and then comes the brownish discoloration of the skin. The other features, like I discussed earlier, includes the diarrhea, vomiting, splenomegaly. There is enlargement of the spleen. Whenever there is an enlargement of the spleen in the size, it is known as splenomegaly. And since the lymph nodes are getting involved, then the infection also spreads via the lymphatic system all over. There is viremia. So we have generalized lymphadenopathy because of the secondary viremia. It is spreading to various organs. So the concerned lymph nodes are getting enlarged. So there is generalized lymphadenopathy because of the involvement of the reticuloendothelial cells. The entire illness lasts for about 10 days. You can see here the rashes in the eruptive stage, the characteristic maculopapular rashes, which are beginning behind the ears on the line of the forehead, and it is seen on the face and the neck, and then extends down the body. Okay. How is it starting? It is starting from the face, then extends to the neck, then extends onto the trunk, down the body, then lastly it enters into the lower extremities. Sometimes the rash will remain discrete, that is confined to an area, but usually it becomes confluent. Okay, one over the other, the rashes keeps appearing. It will be very blotchy, and in the absence of any complications, there will the lesions will disappear, the fever will disappear, and another 3 to 4 days significantly there is an end of the disease. Okay, the rash also fades in the same order of appearance. First the rashes will start fading on the face, then start fading on the neck, they'll start fading on the trunk, then in the extremities they get faded, leaving some brownish discoloration. You can see on the in the picture here, it's beautifully given. They leave a brownish discoloration which will stay for about 2 months or more. So you may have a doubt, if a person have suffered from measles, if your kids have suffered from measles, how long are these spots going to remain on the body? Once the child gets infected with measles, the rashes will remain for 2 months and then they will fade. Okay, you can see here there is fever, high grade fever, red blotchy rashes. They will first appear on the forehead, behind the ears, then face, neck, trunk, and extremities. There is runny nose, cough, coryza, lacrimation, red eyes, inflamed eyes, conjunctivitis, hacking cough and sore throat, and this typical Koplik spot which is found inside the mouth. It is like a salt of grain which is found inside the mouth in the lower first and second molar. Okay, let's move further. Moving further to the complications of measles. So, what are the complications of measles? The severity of measles is going to vary widely. Depending upon the host and environmental factors, the complications will vary. The risk is more in cases of the developing. Severe or fatal measles is increasing for the children who are aged less than 5 years, and especially the people who are living in the overcrowded conditions. We know that the measles is mostly affecting the developing countries. So in the developing countries, usually the people are living in an overcrowded condition, and it is affecting those who are malnourished, and the complications are usually observed in those who are malnourished, especially when they are suffering with vitamin A deficiency and some immunological disorders like AIDS. So let's see the respiratory system. What are the complications seen? The manifestations are due to the generalized involvement of the respiratory tract. Initially, we saw that there is a damage to the respiratory system. There is loss of cilia, which is leading to the involvement of the secondary bacterial infections, and it is leading to laryngitis, croup, otitis media. So we see the ear. There is the infection of the ear, otitis media. bronchitis, bronchiolitis, bronchopneumonia, and secondary bacterial infections are observed. So clear guys, what are the complications you will mention under measles and respiratory system? In the respiratory system, we have laryngitis, croup, otitis media, bronchitis, bronchiolitis, and bronchopneumonia. Moving further to the central nervous system. From the previous slide, we know that it is going to cause measles encephalitis, which is occurring in 1 to 4% of the people. Post infectious measles encephalitis is usually observed. So we'll see acute measles encephalitis, mild to severe or fatal, may be present. So in the encephalitis, the patient is usually going to suffer with fever, headache, drowsiness, coma, seizures. It is resulting from an immune mediated response to myelin proteins. It is post infectious encephalomyelitis usually. Rarely the transverse myelitis. The transverse myelitis is following the measles. The transverse myelitis is usually following the measles. Subacute sclerosing panencephalitis also results from the persistent infection with an altered measles virus. So let us go slow. Initially, there is inflammation of the brain, which is nothing but the encephalitis. And when the patient suffers from the encephalitis, he is presenting with fever, headache, drowsiness, coma, seizures. This is clear. Why does it occur? It is because of immune mediated response to the myelin proteins. From where do these myelin proteins come up with? It is a post-infectious encephalomyelitis, and in cases of post-infection, once the measles affects and it is the viremia, the virus will enter the brain and it will cause the encephalitis. In cases of encephalitis, there is response. In response to this myelin proteins, there is encephalitis. Rarely, including the spinal cord, the transverse myelitis is also observed. Subacute sclerosing panencephalitis, all the three layers are involved. Okay, the panencephalitis is also observed. It is resulting from the persistent infection with an altered measles virus which is harbored intracellularly in the central nervous system for several years. We see there is persistent infection. Even after the rashes will disappear, the infection will always remain in the body, and there is panencephalitis which is occurring. We saw that all the three layers are going to be involved, and the subacute sclerosing panencephalitis, SSPE, is subacute sclerosing panencephalitis is observed, and this virus will be harboring inside the brain for years together. Usually it becomes insidiously. Insidiously is very slowly the disease is going to start, and then we see that after the primary measles, 7 to 13 years, the permanent sequel, mental retardation, progressive dementia, and seizures can come up. Clear, guys? What did we understand? Initially, it will affect the brain. It will cause primary encephalitis. Later on, the disease, the virus is still going to persist inside the brain. It will harbor intracellularly for 7 to 13 years. The disease is insidiously going to occur after the primary measles infection, leading to permanent damage, permanent sequel, permanent result, that is the mental retardation in that person, progressive dementia, there is loss of memory, and there are seizures. Affecting the gastrointestinal tract, it is going to cause gastroenteritis, hepatitis, appendicitis. We see there is inflammation of the liver, inflammation of the appendix, ileocolitis. You can see the intestine. There is inflammation of the intestine, ileocolitis, mesenteric adenitis as well. Measles in adults. Measles is a disease of childhood, and like many other viral infections, it is more severe in adults than the children. It is more severely affecting the adults. Primary viral pneumonia with severe bronchospasms. What does it cause in adults? The measles is going to cause pneumonia. There is bronchospasm. Severe bronchospasms are seen. There are confluent rashes. Hepatitis, bacterial superinfection are the predominant features of measles in adults. Moving on to the rare complications, it can also affect the heart, resulting in myocarditis, glomerulonephritis. You can see here there is inflammation of the glomeruli of the small blood vessels in the kidney. Post infectious thrombocytopenic purpura. You can see the leg here, there is purpura, small spots, and exacerbation of the pre existing tuberculosis. If the person is already suffering with any respiratory complaints like pneumonia, TB, tuberculosis, then the measles attack is going to exacerbate the condition of tuberculosis. In immunocompromised patients who are having a decreased cell mediated immunity, like those patients who are suffering with HIV, who are on the immunosuppressive therapy, we see here examples are the patients with congenital cellular immune defects. So, congenitally, they are having the immune defect in them, and the recipients of the immunosuppressive therapy, malignancy, those patients who are battling with cancer, those who are suffering with malignancy, infection with HIV may have severe, protracted, and fatal measles. Moving further to the epidemiological triad. In the epidemiological triad, we are going to discuss the disease, the measles we are discussing. In relation to that, we are going to discuss about the agent, the pathogen, the host, and the environment. With respect to the agent, let's discuss about the characteristics of the agent, that is the measles virus, how toxic it is, what is the virulency, infectivity, how is it susceptible to antibiotics, the ability to survive outside the body, the eradicate, and genetically modify. The interventions, we remove the breeding grounds, we will improve the sanitation, that is how we can prevent it. And then with regards to the environment, let's discuss about the climate, the physical structure, population density, social structure. Not very important. The main thing is the intervention. What you can do, you just focus on the interventions in this slide. The agent, how can we intervene? How can we prevent the disease? By eradicating the virus and genetically modifying it. And the environment, improve the housing quality, because generally it occurs in the developing countries where the people are usually overcrowded, there is poverty, and once once the people are overcrowded, the respiratory infections tend to spread very easily. The sanitation, improve the hygiene, water quality, preventive services. In the host, the interventions you can see in the environment, in the host, educate the community, change the activity patterns, and also once the person is affected, quarantine him so that he is not contagious to others. With respect to the host, let's see what are the interventions. Treat the host who is affected, and then isolate him, immunize him by giving the vaccine, and provide a good nutrition. Protect the people, educate them. After exposure, we need to educate them. Moving further to the agent factor. Measles virus is a single-stranded RNA virus which is belonging to the paramyxovirus group. So we know it belongs to the paramyxovirus group. It cannot survive outside the human body. It can easily be destroyed by heat, acid, and drying. So this virus can easily get destroyed by heat, by acid, by drying. It gets destroyed. It cannot survive outside the human body. It survives for a long time, especially at the sub-zero temperature. Lower the temperature, longer the duration of the life of measles virus. At 4 to 6 degrees Celsius in the refrigerator, the measles virus will survive up to 6 months. At minus 20 degrees Celsius in deep freezers, ice-lined refrigerators, it can survive to 2 to 3 years. This property is utilized to prepare the live vaccine against the measles, and we keep it in the cold chain. Moving further to the reservoir of infection. Measles is a disease of human beings only, because humans are the only natural host to measles virus. So we have no other host to the measles virus except the humans. There is no involvement of cats, dogs, sheep, cattle. We have only the humans being the natural host to the measles virus. Hence, the only reservoir of infection is in case of measles. There is no carrier state. The infective material, the respiratory secretions of a case of measles. We know the infective material is the respiratory secretions, the aerosols. The period of communicability was 4 days, 5 days before the appearance of rash, and 3 to 5 days before the appearance of rash, and 4 days after the appearance of rash. Measles is highly infectious during this period. Secondary attack, you can write it either ways, it's correct. Secondary attack rate is about 80% among the susceptible contact. So secondary attacks also can occur in 80% of the susceptible individuals. The susceptible individuals are the children less than 8 years of age, the immunocompromised individuals, those individuals who are suffering with HIV. The mode of transmission is by droplet infection. Moving further to the host factors, age incidence, it is highest among the children, especially 6 months and 3 years. It is mostly observed in the developing countries. Infants below 6 months is escaping because of the maternal antibodies they get through the milk. Since this up to the 6 months of age, exclusive breastfeeding is followed in the developing countries. In India, exclusively, since the breastfeeding is done, the child gets antibodies via the breast milk, and these antibodies is providing the passive immunity to the child and preventing the child to contract measles. Sex incidence is equal in both the sexes. Both male and female are affected equally. Immunity, one attack of measles is giving a lifelong immunity to the child. Second attacks are rare in children. Immunity after vaccination is solid and it is long lasting. The nutritional status, malnutrition is increasing the susceptibility of the child. So we see the malnourished child are very susceptible. Measles is becoming more severe in malnourished children. The mortality is about 400 times higher in a malnourished child compared to a healthy counterpart. We see the mortality, the death, the chances of death is 400 times higher in cases of a malnourished child. So we see in the developing countries, the poor communities are more susceptible to measles, and the malnourished children in the slums, in the backward communities, in the developing countries are more susceptible, and they have 400 times higher fatality rate compared to the healthy counterpart. This is because of the poor cell mediated immunity due to the malnutrition. In addition, the measles will precipitate even a healthy child, it will precipitate a healthy child into malnutrition. Environmental factors, it is usually observed in the temperate climates. Measles is commonly seen during the winter season since it's a respiratory tract in disease. So it is usually observed in the winter seasons and early spring, that is Jan to April. Moving further to the levels of prevention, the severity of health impact increases. The primary prevention, the target is once there is an onset of disease, we are preventing it. The secondary prevention is we are preventing the progression of disease. There is already the onset of disease has already occurred. We are just preventing the progression of disease in the secondary prevention. In tertiary prevention, the disease is already established in the body, so we are targeting the complications and disability. We are trying to prevent the complications, what we discussed earlier, the various systems and the complications of it, and we are trying to prevent the disability in the individuals. So let's see what is the primordial prevention. Primordial prevention includes the health promotion. This consists of the general measures which will strengthen the individual or host, and it will prevent the occurrence of disease. So we are taking general measures so that we can strengthen, we can improve the immunity of the individuals, so that we can prevent the occurrence of the disease by interrupting the interaction among the three factors of epidemiological triad. So we are interrupting the interaction. So if it is the host, we are trying to isolate the host and interrupting the interaction among the three. The various measures of health promotion are health education. We need to educate the people about the personal hygiene, about the oral hygiene, nutrition education to maintain a balanced healthy diet, lifestyle changes, etc. Also the sex education, providing adequate nutrition, improvement in the environmental sanitation. How can we improve the sanitation? By controlling the insects, the breeding of insects, by discarding the waste which is surrounding our environment in our houses nearby. So we are controlling the insects, the provision of the protected safe water supply, the sanitary disposal of the sewage. Very important, the disposal of the sewage, the sanitary disposal of sewage have to be done. This is the improvement we need to bring in the environment, so that we can prevent the occurrence of measles. Also, the promotion of breastfeeding and proper weaning. So once we promote the breastfeeding, the antibodies and the good immunity will be transferred to the baby, so he will be protected to the various infections in his childhood. And proper weaning, so that baby doesn't go into the malnutrition. We need to educate the mothers to provide the proper weaning. That is, weaning is nothing but the baby will start taking highly nutritious protein and proteinaceous food from about 6 months of age. They'll start eating food, that is the weaning period. The family planning and spacing of the birth, so that we can prevent the overcrowding and the poverty, and prevent the measles. And improvement in the literacy level will have a greater impact on preventing the diseases. The primary prevention, we are doing a specific protection. So here we are just promoting the entire community. Primordial, the disease has still not yet occurred. We are just doing the health promotion so that we can prevent the disease from entering into our community. Specific protection is immunization. The measles vaccine has to be given. What is the nature of the vaccine? It is a live virus vaccine, a single antigen, and is freeze dried vaccine. We know the live attenuated vaccine is prepared because the measles virus can last up to several months in cases of freezers, ice-lined refrigerators. So we are using this property of this virus and preparing a vaccine of a single antigen, and is a freeze dried vaccine. Moving further to the composition of the vaccine, each dose of 0.5 ml is containing not less than 1000 TCID50 tissue culture infective dose. So TCID is the tissue culture infective dose. It is a live attenuated vaccine, Edmonston Zagreb strain of measles virus. It is propagated in the human diploid cells. So this is the composition, not very important. You need to remember the immunization, the specific protection is given by the measles vaccine. The diluent, the sterile distilled water is used. The dose of the measles vaccine is 0.5 ml. The route, it is subcutaneously in the upper arm. How do we inject the measles vaccine? Subcutaneously on the upper arm or the anterolateral surface of the thigh. Okay, let me just draw and show you. So it is given here or on the anterolateral part of the thigh. Okay. Scheduled only one dose during the 9th month of the infancy. We give the measles vaccine. Immunity, it will develop 10 to 12 days after the vaccination, and it gives a lifelong immunity. The protective value, one dose confers 95% protection. Only 5% failure rates are seen. The storage of the vaccine, the cold chain must always be followed. The vaccine will retain its potency for more than 2 years at 2 to 8 degrees Celsius if the vaccine is stored. If the cold chain is followed, if it is stored in the cold temperature, then the vaccine will last up to 2 years when it is stored at 2 to 8 degrees Celsius. Age, immunization is not recommended for children before 9 months of age. We don't recommend measles vaccine before 9 months because the vaccine is rendered ineffective by the maternal antibodies. They will protect the child up to 9 months. So the maternal antibodies which are transferred to the baby via the breast milk will provide a protection to the baby from the measles up to 9 months. So even if you give the vaccine, it is not effective. But under the situation of epidemic of measles, or if there is a history of contact with the case of measles, or the measles vaccine can be given as early as 6 months of age. If there is a history, if the baby is suffering from measles before the 9 months of age, in such cases you can give the measles vaccine. Also, if there is an epidemic in that community, if the country or the community is suffering with an epidemic of measles, then even the infants less than 9 months of age age can be given the measles vaccine. However, such children will require a second dose during the 15th to 18th month of age. First dose, if you give it before 9 months of age, the second dose have to be given from 15 to 18 months of age. The contacts young susceptible children who are coming in contact with active cases of measles can be protected from measles by the vaccine. If the vaccine is given within the 3 days of exposure, then the individual can be protected. Because the incubation period of the measles, the artificial infection is 7 days, whereas in natural infection, it takes up to 10 days. So, if the person, did you understand this point, guys? If one individual got affected by another active case, okay, this is an active case of measles. If he got affected by this active case of measles, then within 3 days, if you give the vaccine, he will be protected. Because naturally, for this infection to get established in the body, it takes up to 10 days. Artificially, the vaccine plays a role, and within 7 days, the artificial infection gets established and the person will be protected. Reaction: in 15 to 20% of the vaccines, the attenuated virus will multiply and induces a mild measles illness up to 8 to 10 days after vaccination. So we know that it sets up an artificial disease. The vaccine, which is nothing but the isopathy, it was founded by William Lux, and we know this in the pharmacy part. What happens in cases of isopathy? The same infective material which is causing the disease is used to treat the disease. So the same virus will be taken, it will be attenuated, then injected into the body. It will set up a mild illness, make the body very immune. So whenever the infection occurs, the actual natural infection occurs, the body has the capacity to fight that infection because of the memory which is created by this artificial vaccine. So once the artificial vaccine is given, it is after 8 to 10 days, the artificial illness, mild illness, is characterized by fever lasting for 1 to 2 days. It is followed by the rashes for 2 to 3 days and followed by the recovery. The virus does not spread from vaccines to contacts. Moving further to the contraindications in cases of the vaccine. Acute febrile illness, the diseases of the nervous system. So the individuals who are suffering with the diseases of the nervous system, who are suffering with convulsions, decompensated heart diseases, who are on an active steroid therapy, who are undergoing radiation, who are on immunosuppressive drugs. However, the mild illness is not a contraindication. The malnourished children deserve the immunization mostly. What are the adverse effects of these vaccinations? The mild measles illness in 15 to 20% of the recipients. Encephalitis, 1 in 1 million vaccines. That is the subacute sclerosing panencephalitis. Anaphylactic shocks are very rare. Most dreadful complication is the toxic shock syndrome. It occurs due to the contamination of the vaccine by the staphylococci. The contamination occurs if there is delay in the use of the vaccine after opening the vial. So if there is any defect in the cold chain, if the cold chain is not properly followed and the vial is kept open and the vaccine is used after a delayed period of time, then it leads to the most dreadful complication, that is the clinical toxic shock syndrome. It is characterized by high fever, vomiting, severe watery diarrhea within few hours of vaccination. Death may also occur within 48 hours. The case fatality rate in cases of the toxic shock syndrome is very high. It is preventable. The occurrence of toxic shock syndrome reflects the poor quality of the immunization services. So if the individuals are suffering with the toxic shock syndrome, it means that the cold chain is not properly followed. The immunization services are not effectively transmitted to the society. Moving further to the secondary prevention. Secondary prevention is done in cases of individuals who have already established the disease. So we need to make a proper earlier diagnosis, a prompt diagnosis, and giving a quick treatment. This helps in the following ways. It helps in recovery from the disease. It helps in restoring the health. It will reduce the duration of illness in the individual. The quick recovery will reduce the duration of the illness in the individual. It will minimize the suffering of the patient. It will prevent the development of any complications. It prevents the further spread of the disease in the community. It will also prevent and postpone the death of the individual. Moving further to the tertiary prevention. Tertiary prevention can be adopted by two modes of intervention, that is, disability limitation. We need to limit the disability which can occur because of measles, and also the rehabilitation services can be provided to those individuals suffering with measles. Lastly, let's discuss about the diagnosis. It is primarily clinical. A specific diagnosis can be made by staining a smear of respiratory secretions. So we can take a smear of the respiratory secretions and make a specific diagnosis. Measles virus can be demonstrated by culture, or it can also be detected by polymerase chain reaction. So you can demonstrate the measles by the culture. We saw the picture already, the histological slide, and we can also demonstrate it by culture or the polymerase chain reaction test. Specific IgM antibodies will be detected within 1 to 2 days after the onset of rash. Once the disease gets established in the body and there is appearance of rashes, you can detect the IgM antibodies. And the titer of IgG antibodies will rise significantly after 10 days. After 10 days, the IgG comes into play. The whitish, we are discussing about the diagnosis. So what do we see? The whitish coating on the tongue early in the illness. The strawberry red and bumpy tongue, very red throat, red and swollen tonsils, swollen lymph nodes in front of the neck, tiny red spots on the root of the mouth called as petechiae, white patches or streaks on the pus of tonsils. So the differential diagnosis will continue with the scarlet fever. The first differential diagnosis is the scarlet fever. We are continuing with the scarlet fever. The causation, it is also including the group A streptococcal infection. It is mainly affecting 5 to 15 years of age individuals. Fever, the signs and symptoms will include fever that is more than 101 degree Fahrenheit, chills, sore throat, pain when swallowing, headache, malaise, abdominal pain, nausea, and vomiting. You can see the other clinical signs and symptoms what we discussed about the scarlet fever. There is a white coating on the tongue. There is strawberry tongue, red cheeks, a rash of the scarlet fever. You can see the white patches, white coating on the tongue, strawberry, red and bumpy tongue in cases of scarlet fever. Moving further to the other differential diagnosis, we have infectious mononucleosis. Infectious mononucleosis is also called as mono or kissing disease. It is an infection with Epstein-Barr virus. Infectious mononucleosis is characterized by the swollen lymph glands, fever, sore throat, and extreme fatigue. Symptoms can take between 4 to 6 weeks to appear and usually do not last beyond 4 months. Liver involvement, like the mild liver damage, can cause the temporary jaundice. There is yellow discoloration of the skin, the whites of the eyes. Because of the abnormal high levels of bilirubin, we have jaundice-like appearance. We have yellow discoloration of the skin, the white of the eye. There is yellow discoloration because of the increase in the level of the bilirubin in the bloodstream. And mononucleosis usually will last for 1 to 2 months. So you can see the picture of infectious mononucleosis here. Centrally, we have fatigue, malaise, loss of appetite, headache, visual symptoms, photophobia. Tonsils, there is reddening, swelling and white patches. Throat, there is soreness and reddening. Lymph nodes are swollen, chills, fever, ache. Respiratory, we have cough, enlargement of the spleen, splenomegaly. Abdominal pain in the stomach, there is nausea, and atypical white blood cells which are characterized by Epstein-Barr virus infection among the red blood cells. Moving further to the other differential diagnosis, that is Kawasaki disease. Kawasaki disease is predominantly childhood disease. Vasculitis has a strong affinity for the coronary disease. So under the inflammation of the blood vessels, we have Kawasaki disease, which is having a predominant or a strong affinity for the heart, that is the coronary arteries. Most patients are under 5 years of age. They'll suffer with fever. You can see the conjunctival congestion here in the picture, beautifully given. Even the baby's eyes, you can see the conjunctival congestion. Inflamed oral mucosa, cervical non-suppurative lymphadenopathy, cutaneous manifestations as given. Thank you. With this, we come to an end of our session, measles. I hope all the things are clear. If you have any doubts, please put them down in the comment section. And if you like the video, hit the like button and subscribe.